Hi everyone, Dr. Wiseman here. Moving into renal function and regulation, which in the new textbook is now 24 and 25. You may have a PowerPoint that says 25 and 26. That's from the old book, and now we're in 24 and 25 as of fall of 2025. Even though kidneys are most known to be involved in the creation of waste products, they're actually quite fascinating from a functional standpoint. You have two of them. Part of the reason you need two is that there's a little bit of a fail-safe mechanism here. That is, if one fails completely, you still have another one. You're not down. You're not down for the count, if you know what I mean. The other really interesting thing about kidneys is that they're actually retroperitoneal. They're actually found behind the peritoneal cavity. They're outside of the peritoneal membrane. And so you have these two kidneys here, which are roughly about the size of your fist. They receive a huge amount of blood. Fully 20% of cardiac output goes to the kidneys. Now, the kidneys do not actually create urine per se. They create filtrate, which then passes down these ureters to the bladder. It's not until you reach the bladder and then begin voiding that material that you actually have urine. That's because we are continually processing things, and there is a dynamic aspect to it. So when we talk about what will be fluid that becomes urine, we call it filtrate. And we process that filtrate. We reabsorb a huge amount of that material. Of the 100% volume that goes into, so if we say the amount of blood going into this kidney, 100%, 99 of that 100% is going to be retained. Only about 1% actually makes it out into that ureter down to the bladder. It's pretty astonishing. And when you think about life in dry, not immersed in water, it's you can see how important that might be. From an anatomical standpoint, I think this is a pretty good summary of some of the key structures, if you will. You have the kidneys themselves, but you also have adrenal glands, and certainly we have arteries and veins servicing these kidneys. We certainly have the ureter coming out of here, which heads down to the urinary bladder. All right. So this is actually a pretty good slide for starters when it comes to at least the macro anatomy of the urinary system. Because kidneys are so important, we have two of them, they also have an interconnecting set of protective tissues around it, not the least of which is the rib cage. The kidneys are actually tucked up inside the rib cage, close to the spine, as you can see here, but they also have overlapping, layers of protection. So we have this renal fascia, and this is the anchoring system. It anchors the kidneys and adrenal glands. You also have a fairly substantial fat pad to protect the kidneys. Now, kidneys certainly do not handle direct stress, like in the form of trauma, very well. And they also require a fairly robust perfusion. So if you get untoward pressures or bruising or anything along those lines, it could be incredibly problematic for the individual. So you have a fairly robust fat capsule, again, as a cushion, protecting the kidneys from undue kinetic stress. And then lastly, we have the capsule per se, which is a very fibrous, very durable. If you've ever worked with a kidney, now here in the United States, we don't typically consume kidneys as food. I know some of you are probably wrinkling your faces as I mention that. Nevertheless, they're incredibly nutritious organs. In fact, skeletal muscle is actually surprisingly among the least nutritious tissues you can consume. But be that as it may, if you've ever worked with it in a kitchen or a dissection, you'll know that renal capsule is incredibly durable and difficult to cut. And here we have a nice organ level anatomy, if you will. And here's a little bit of a way to think about rather than trying to identify. There is a system that you can use in order to work your way down to the finer and finer. And that is, we have the renal artery itself. Then we have segmental arteries. So once you see the renal artery branch, like this one here or this one here, those are segmental arteries. And then the next branch, you would have interlobar arteries. So these ones right here are interlobar vessels. Then the next one would, at the next branch, you would have these arcuate, and we have some other pictures of this. And then finally, you have these radiate, which means, like radius. Okay, they're radiating out in sort of this perpendicular to the edge of the renal capsule here. You have an outer area known as the cortex. In fact, we have a cerebral cortex in the brain. Same thing. It's the outer surface area. And then you have these pyramids. Okay, these are actually important for osmotic regulation. You have the pelvis and the calyx, and then finally the ureter. But inside that cortex, and this includes the pyramids and all this other fun stuff, this is known as the middle, or in Latin, medulla. All right, so you have the cortex on the outside, and you have the medulla and associated structures in here. All very good for anatomy purposes, this picture. Focusing in on the blood vessels, it really comes down to the big one is renal. Then the next division would be segmental. The next division would be interlobar, and the next division would be arcuate. And then you have these radial arteries at the very, very end. All of the functional action that occurs in the kidney is generally happening at what's called the level of the nephron. All right, we have somewhere around 2 million nephrons in our bodies, 1 million in one kidney and 1 million in the other. It's comprised of a glomerulus and then this tubule that leads to what's called a collecting duct, and that eventually goes to the ureter. Eventually, it's not there yet. This is the functional nephron. Now, you do have two populations. You have what's called a cortical nephron, which is most of the tubule is found in the cortex, and that seems to be involved with secretion reabsorption, with one exception, water. This loop of Henle here, or sometimes they call it the medullary loop. Notice that in the juxtamedullary nephron, that loop goes way, way down in there. This is all about water. Water, 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 water. In fact, even the collecting duct, as it moves down through the pyramid and into the pelvis of the kidney, is also absorbing water. Remember that we are terrestrial animals. We really don't have ready access to water if you think about, living on the savannas of Africa and that sort of a thing. All right. So we do have some secretion reabsorption going on here, and we certainly have it here as well. But these juxtamedullary nephrons seem to be much more engaged in water conservation. There's still a little bit going on here, but not nearly to the extreme. In fact, there are animals in this world that never drink a drop of water in their lives. And these juxtamedullary nephrons can go way, way down to the point where they even penetrate out of the pelvis of the kidney. You can actually see a special extension of the capsule. At the upstream end of the nephron is an incredibly specialized structure known as a glomerulus. So specialized that we have yet to figure out how to grow or regenerate a glomerulus, assuming it's injured or lost. We can grow lots of tissues. We can grow skin, we can regrow blood cells and hair and all sorts of things, even certain neurons, but not the glomerulus. It's actually too specialized at this point. It's a 3-layer system. So you have specialized endothelial cells, which are shown here in red. And these endothelial cells have holes that don't go inside the cell. They go through the cell. They are specialized projections of plasma membrane that create these channels from the lumen of the glomerulus out into the capsule, which collects the filtrate, called Bowman's capsule. And so that's part of the filtration. It doesn't pass through the cell in terms of crossing the plasma membrane, but it does pass through the cell through these fenestrations, and that's why it's a filtrate. Then you have these podocytes, and they're called podocytes because they have these specialized projections, these finger-like projections. And if you put your hands together with your fingers interlocking, that's how podocytes relate to each other. And you can actually, in your kidneys, those podocytes can get closer together or they can get further apart, thus modulating the filtration ability of the glomerular filter. So it's a three-layer system. You have the fenestrated epithelium with these fenestrations, these channels. You have the basement membrane, which serves as a sort of electrostatic filter. It's slightly negatively charged, and so it helps prevent negatively charged things like ions or other biomolecules. It's just like an electrostatic filter that you buy from one of those specialty stores, you know. It's electrostatic, prevents the negative charges, or at least hinders the negative charges from passing through that basement membrane. And then we have the podocytes, which can again be closer together or further apart. That's our three-layer system. Now, kidneys do have a laundry list of functions, among which waste removal is one of the, I don't know, sometimes you could argue lesser functions. Well, you know, waste is important. You got to have dialysis to survive. But there's a lot going on, and we need to at least have some awareness of those major functions. Not only do we get rid of waste, but kidneys are a key aspect of regulating total water volume. You're losing water all the time through exhalation, through sweating, evaporation, and certainly removal of urine. You're voiding water in that case. But we have to regulate it. Your kidneys can't adjust if you are hypovolemic, all right, dehydrated. But alongside of regulating water, it also regulates the material that is dissolved and suspended in that water, what we call solute. All right, and that solute concentration can be also manipulated by kidneys. Along those lines, ions. Okay, so some of the solutes that we regulate are ions. All right, and when we regulate ions in the blood plasma, that means we can begin affecting ions in other compartments we call extracellular fluid, like interstitial fluid, for instance. One ion, actually two ions in particular, are the H plus, a proton. That's what makes acid, or the OH minus, the hydroxyl anion. That gives us a little bit of base. All right, so if we're going to regulate ions as a part of the solute, one of the most important ions is the proton and the hydroxyl anion. Yeah, we get rid of things that we need to get rid of, which include nitrogenous waste or metabolites that have been detoxified, or compounds which are deemed unnecessary to normal physiologic function. A lot of those include drugs or the things that we consume in our food. The kidneys also play a role in regulating how many red blood cells you have. They create this signal. It's a hormone called erythropoietin, sometimes abbreviated EPO. And when erythropoietin is created, it will drive bone marrow cells to shift the rate of cells to red blood cells. And we exploit that when people are on chemotherapy or for suffering from certain forms of anemia. We can give them EPO to help them increase their red blood cell count. Along the lines of regulating extracellular fluid, a key hormone is known as renin. And it's part of the renin angiotensin-aldosterone system, or RAAS. If we regulate extracellular fluid, okay, we regulate blood pressure. Okay, so this is all connected. It's just a spider web of connected concepts and mechanisms. Now, here's one that feels kind of random. Vitamin D. You know why vitamin D is so important? It's involved in calcium homeostasis, back to our ions. Okay. And that's something that I'm trying to encourage you to think about. You could memorize these things absent of context, but when you see the connections between them, I think it makes it easier to remember and also arguably more interesting. Now, kidneys also, like the liver, can create glucose. So when you wake up in the morning, your liver is actively creating glucose from a molecule called glycogen, or in more extreme circumstances, can be creating it from certain amino acids. Same story here in the kidney. The kidney can also contribute glucose to the blood plasma through this process known as gluconeogenesis. Again, recall that we are not creating urine in the kidney, we are creating filtrate. And some numbers to help you see what's going on. We can make about 1.5 liters of urine out of well over 180 liters being processed. So that's less than 1%. Okay, the entire plasma volume each day 60 times. That's pretty extraordinary. Fully a quarter of the, or a fifth of the oxygen that the body consumes is consumed by the kidney. So we're creating filtrate that then is moved through the ureters to the bladder. There, some final situation going on that creates the urine that's actually removed. So less than 1% of that original filtrate is now leading to urine. Okay. So we have the filtration in the glomerulus, and it should be cell and protein free. It should have some ions, things like glucose, then calcium, all sorts of things, and a lot of it has to be retained. That retention of water and potentially valuable molecules is called reabsorption. We have filtered it, and now we are reabsorbing it back into the blood plasma. There are processes as well that actively remove things from the blood plasma. Maybe they don't filter, maybe some of it filters, or maybe none of it filters. And so it has to be removed by a process called secretion. So if we move things from the blood plasma, extracellular fluid, to the kidney filtrate, that is known as secretion, and tubular secretion in particular. We are reabsorbing a huge amount of water, all right, and that can vary depending on your situation and how dehydrated you might be, or are you fluid challenged and need to excrete more fluid, et cetera, et cetera. Finally, when we have urine, we need to remove it from the bladder. So we call that micturition or voiding, or more colloquially, urinating. Given that even moment to moment, like for a moment, let's say you're sitting here right now listening to my voice at rest. Now, let's say you got to get up and go do something. Even just in those few seconds, your blood pressure is going to change, your cardiac output's going to change. And so we have a very, very dynamic cardiovascular system. We have behaviors that may be more or less, metabolically active. Well, we have to maintain a relatively stable rate of filtration. And filtration can be affected by changes in blood pressure and so forth. So clinically, we have developed this understanding called GFR, which stands for glomerular filtration rate. All right. That's the number of milliliters of filtrate created per minute. Right. Normally it's around 100 and 125 milliliters per minute. So net filtration pressure is mostly due to what we call mean arterial pressure in the blood. They call it glomerular hydrostatic pressure. I wish they would kind of tighten these definitions up rather than deviating into this new term. Let's just call it what it is. It's actually mean renal arterial pressure. Filtration is also affected by how many glomeruli are available. So if this is one of the things that makes sepsis so dangerous, and sepsis is when you have an active infection in your blood. And when you have an active infection in your blood, that can then lead to protein antibody complexes that are big enough that they will actually hang up in the glomeruli and prevent filtration from happening, and you can die of acute kidney failure. And you also have, the number of glomeruli involved, and if you have chronic kidney failure, you're losing glomeruli for various reasons. The third thing that can affect surface area is there are cells that can contract and affect the podocytes. They're called mesangial cells. And if they contract, they can reduce surface area transiently. Lastly, the membrane itself. All right. If the membrane is damaged or becomes inflamed or is attacked in autoimmune situations, or back to our sepsis situation, that can affect what we call the coefficient of permeability. So if we're losing too much, oftentimes due to this a loss of functionality of the membrane, you're going to lose electrolytes and certainly going to lose fluid. Now remember that we're only micturating less than 1% of the total volume. If you went to 1.5%, you'd be peeing fully almost double what you're already peeing right now, which feels like a lot sometimes. So imagine just a small change could lead to a doubling of your urine output. Never mind the dehydration complications from that. And if we have too low, for instance, maybe there's a loss of perfusion or a fibrin. You get fiber deposition in the filter and it no longer filters properly. We can get what's called azotemia, which is a buildup of nitrogen products in the blood. Certainly cerebrotoxic. It's toxic to neurons, can cause delusions, lower loss of consciousness, and even death. In the blood, if we measure it, we call it azotemia. Now, in a more visual way, so as blood comes in what's called the afferent arteriole, it has a certain intrinsic pressure, which we call glomerular hydrostatic pressure. And it's pushing fluid out of the blood plasma into the glomerular capsule. So we call that glomerular hydrostatic pressure. And you can see the number here. It's just good to kind of understand the majority of the pressure is out, and that is hydrostatic pressure. Then we have what's called capsular hydrostatic pressure. That is the fluid found outside of the glomerulus that's actually pushing back in. This becomes incredibly important if we're talking about kidney stones or any type of occlusion, malformation that leads to fluid buildup. As that fluid builds up, this value will increase, which is counteracting the outer pushing pressure. All right. So kidney stones or anything what we call hydroureter, very dangerous. Acute kidney failure, that's because fluid is now trapped and the hydrostatic pressure from the capsule is now pushing more back in, reducing filtration rate. The third one's a little trickier to wrap your brain around, and now you know why we study osmosis, okay? You might wonder, why do I need to know osmosis? It's because of right here, right now. The proteins and the ions inside the blood have a higher level of osmolarity, which will pull water back in. Water wants to move down its concentration gradient. So if you have less solute, there is more water. And if you have more solute, there's less water. And inside the blood plasma, there's more solute. And so there is this pulling motion of osmosis, water coming back into the glomerulus from the capsule. So we have the out pressure, glomerular hydrostatic pressure. We have a pulling in osmotic pressure, and you can see that number right there. And then lastly, we have this small amount of hydrostatic capsular pressure. The net should be somewhere around a plus 10, plus being out. All right, if we had a minus something, it'd be more fluid being pulled in than pushed out. So we have 55 minus 30, that gives us 25, minus 15, that gives us 10. A key way of manipulating filtration rate relatively quickly is through the effects of that afferent and efferent arterial. So if we reduce the afferent, that means less fluid in, and if we dilate the efferent, that means more fluid out. That means we would have less pressure and less filtration. If we increase the fluid coming in by dilating and reduce the fluid going out in the efferent by constricting, we get more fluid, which means an increased filtration because of increased pressure. Take a little bit of time with this. Don't get lost. Take your time. Think of the afferent. Here's a sort of a colloquialism. Think of it as a sort of a sink. And you've got control of how much fluid comes in the faucet, and you have control of how much fluid goes out by the drain. So if you open the faucet and you close the drain a little bit, you're going to get more water in that sink. Vice versa, if you close the faucet and open the drain, you're going to have less water, and water is synonymous with pressure in this case. To bring this to a more systemic level, we want to keep GFR really, really stable, even though we can have incredible changes in blood pressure, blood flow, and so forth. So we can use muscles like we described with the afferent and efferent arterioles to regulate how much filtration occurs. All right. We actually have a feedback mechanism. The tubule actually has apparatus that is capable of sending signals to those afferent and efferent arterioles to say, hey, the urine's too concentrated, or hey, the urine's too dilute, and so forth. Cardiac output, all right, blood vessel constriction and dilation along with feedback. Then we also have external controls. We have hormones that can affect how the kidney retains fluid. There are some neural pathways as well through the autonomic neural system. And we have gravitational and other means of affecting arterial pressure. That can include body mass and or position in space and so forth and so forth. I'm not going to recite this too much. I've already done it in the previous slide. So for time purposes, this is just showing you how you can affect the afferent and efferent arterioles. All right. The feedback mechanism that can control those arterioles and so forth. So read through this slide, read through the book, and you should be in good shape. This picture right here shows you the specialized cells that are involved in regulating the constriction and dilation therein of these afferent and efferent arterioles. The flow and the osmolarity of the filtrate affect whether these cells send a signal or not. Now, here's how you can envision this. Take your hands and hold them out in front of you with the fingers not fully extended, but just about half extended, so like you're clawing something. Now I want you to take your right hand and close it. Leave your left hand as it is. Now what we're going to do, so the right hand is actually a constricted vessel, while the left hand is just in a regular position or dilated. So now let's flip them. So we're going to close the left hand and open the right hand. And then we're going to go back to closing the right hand, opening the left hand. That's how these vessels behave. The signals that come off of what is known as the juxtaglomerular apparatus, or they call it the juxtaglomerular complex, these cells, when they send the signals, it causes that response. Either it's going to cause constriction in one vessel and opening the other more, or it's going to do the opposite. It's going to constrict and open in the opposite direction. All right, pretty cool stuff. All right. They have receptors here that basically feed back on the blood vessels that service the glomerulus. This flow chart, and it is a flow chart here, looks more complicated than it actually is, and it sounds intimidating. The renin, angiotensin, aldosterone system. Oh my God. Well, hold on. Hang in there. So those juxtaglomerular cells that we were just talking about that are involved in regulating the constriction dilation of those arterioles, they can also send out signals that go out into the rest of the blood plasma that cause more systemic responses. So let's what happens. So when we sense low blood pressure, or if there's very little sodium in that filtrate, those cells will release renin. It's a hormone. That's the R. That renin actually is a type of enzyme that will convert this precursor, this angiotensinogen, and that's a mouthful, I know. It will chop that protein that's coming out of the liver into a molecule known as angiotensin 1. Angiotensin 1 is now circulating through the blood, just minding its own business, and in the lungs in particular, but in other places, there are enzymes in the lining the blood vessels of the lungs called angiotensin converting enzyme, or called ACE. ACE enzymes, and there's more than one, are also going to chop angiotensin 1, chopping off pieces of it, and now we have angiotensin 2, and this is now an active hormone, and it packs a wallop, okay? So renin causes the first step of angiotensin activation. This isn't active yet. It's just one. ACE is part 2 of that. So we have angiotensin 2. It affects the kidneys, which lead to aldosterone hormone. And aldosterone affects the kidney reabsorption, all right, in the kidney, but can also have some ancillary effects. We're going to talk about those. It can affect secretion of antidiuretic hormone from the posterior pituitary. It can cause vasoconstriction, so that you're retaining fluid, and some other things, including thirst. And so it's very, very potent hormone, angiotensin 2. By the way, just in a little bit of an aside, the COVID virus actually gets into the lung cells through the ACE for reasons we don't fully understand. The virus can bind to ACE, and that's why COVID was preferentially a lung disorder. Well, it still is. It still is a lung disorder. All right. Part of the reason why you get a cough. All right. In any case, renin is released from the kidney. It's converted by it converts angiotensinogen and through a two-step process, angiotensin 2. Angiotensin 2 then goes out and notably creates aldosterone, which does other things, and that leads to increased fluid retention. So if you are hypertensive, if you got too much blood pressure and we want to get rid of some of that fluid, one of the ways that are very, very powerful is that we can give them a drug that blocks the creation of angiotensin 2, and we call that an ACE inhibitor. And trust me, as nurses and healthcare practitioners dealing with, especially folks that have, high blood pressure is very, very common. One of the most common drugs you will see in clinical practice are ACE inhibitors. Here we have 3 main hormones to know. So we have renin, which is actually an enzyme that's not shown here. That's the one that helps create angiotensin 2. Right? Angiotensin 2 actually gives rise to antidiuretic hormone, among other things, and aldosterone. Aldosterone primarily acts in the kidney, Antidiuretic hormone also acts in the kidney, but it's released by the posterior pituitary. So it's a pituitary hormone that then has an effect in the kidneys. Now, this is a pretty busy flow chart, and I encourage you to work through it step by step. All right. I don't think you need to memorize it so much, but as see what we've been talking about up to this point. And when you do that, hopefully this will bring some of it together in terms of this sort of interconnectivity. But we have sympathetic nervous system that can affect this, and that includes not the least of which cardiac output, vascular tone. All right. We also have hormone controls, and the big one for us is the renin, angiotensin, aldosterone system. All right. And so we can now have a coordinated, overlapping, redundant system of managing blood pressure, fluid volume, ions, etc. Recall, if you will, that if the volume entering the kidney in terms of blood plasma is 100% and we are retaining more than 99% of it, then tubular resorption becomes super critical. All right, it's what reclaims most of the volume that we filter. It is selective. All right, it is generally selective. We are retaining water, nutrients, and ions, and it is affected by hormones, including aldosterone and antidiuretic hormone. There are active processes. Those active processes are generally what we call transcellular. That is to say, they are going through cells on their way back into the blood plasma. And we have what are called paracellular processes, where the gaps in between the cells can and do affect material that's moving either to or from the blood plasma and the filtrate. Again, another fairly busy slide. Don't want to delve in too much into this. This will just make your eyes cross. This is the key right here, is that 65%, 2/3 of the volume that's going to be resorbed is going to occur in this structure just immediately downstream of the glomerulus, called the proximal convoluted tubule. All right. And it's going to be a combination of active processes and passive processes. We don't need to get into the specifics therein. Almost any ion, a lot of nutrients like glucose or that sort of a thing, even some nitrogenous molecules like uric acid and urea, which we think of as waste, and they will, about half of it will become waste, but some of it's also retained for physiologic purposes. But just in that first segment there, even before we get to the medullary loop, or sometimes known as the loop of Henle, 2/3 of the volume has already been reclaimed in the proximal tubule. There are times when the resorption apparatus, which depends on proteins and so forth, and if it depends on proteins, that means there may be a maximum of transport. Just like if you have 5 firefighters, how big of a fire can you actually fight, right? But if you had 500 firefighters, now you could fight a bigger fire. And that's the way that these proteins behave. They can get saturated, all right? So the number of carriers that's there, and it turns out those hormones we've been talking about, aldosterone, antidiuretic hormone, they can actually affect that number. All right. In any case, let's say you have a passion for donuts. All right. Maybe if you are disciplined and you only eat, a small donut, most of that glucose that you've consumed in that donut will be, first it'll filter. It's not charged enough and it's small enough that it'll filter. Well, we want it back. Well, we can get almost all of it back. But if we had 2 donuts or 3 donuts or 6 donuts, if we actually measure the urine, you will see that a lot of that sugar beyond a certain point is now spilling out into the urine. We call that glucose spill. Folks that are hyperglycemic or folks that have just had a meal oftentimes have elevated glucose in their urine, which is why when we do urine sampling, we want the patient to give urine in a fasted state so that you don't contaminate the urine with excess glucose what we call postprandially after a meal. So if we're going to filter something, it passes through the glomerulus and then we're going to reabsorb it. If we can't resorb all of it, some of that resorption is going to end up in secretion, or not. Some of the unresorbed will end up in secretion. Now, if we have other things that we are going to pull out of the blood plasma and deliver to the filtrate, that will also end up in excretion. So a ridiculously simple formula. Whatever we filter minus whatever we resorb plus whatever we secrete equals whatever we excrete. So that reabsorption, proximal convoluted tubule is the site of roughly 2/3 or so of the volume. It's actually extremely difficult to use any drugs in this side of the kidney because it's so powerful. If we even affect urine excretion by 1%, that could double your urine volume. All right. So proximal convoluted tubule is extremely important. And then the next one, the loop of Henle, sometimes we call it the medullary loop, or we call it the nephron loop. There's lots of names for it. This is really about water conservation. So as the loop descends down into the medulla of the kidney, into those renal pyramids, it will resorb water. On the other hand, as it is coming back up towards the cortex, it is water impermeant. All right. Solutes can be removed and are actively removed, but water can't. So we let water out on the way down, but then we hold on to water on the way up so we don't just give it back. All right. Pretty interesting mechanism. I'd love to talk more about it. I'm going to leave it there. Finally, we get to the distal convoluted tubule and the collecting duct, both of which are active parts of the nephron. So then now we're downstream of that nephron loop. We do some fine tuning in here. This is where antidiuretic hormone and aldosterone really do their thing. They can affect additional water conservation if needed, or reduced water conservation if the water needs to be removed. You have too much fluid. Both of these hormones play a role here. And what I like to say about the distal convoluted tubule and collecting duct, this is where we do the fine tuning. And this is where most of your drugs that are involved in kidney excretory function do their thing, because they are the fine tuning side of the equation. So now we've covered filtration, we've covered reabsorption. Now let's get to the secretion side, and almost all of it occurs in the proximal convoluted tubule. We are going to actively move substances from the blood plasma and shove them into the filtrate. Drug metabolites, toxins are all key targets of tubular secretion. If it doesn't filter, we have to have some other way to get it to the waste, and that is through what we call tubular secretion. So if the kidneys are extremely efficient at retaining over 99% of the volume, what we're going to do is we're going to mostly affect the distal convoluted tube and collecting duct, maybe a little bit in the loop, not a ton, but most of the fine tuning is occurring distally. We have these mechanisms, they're actually anatomical mechanisms. That is to say, the filtrate flow goes in the opposite direction in space as the blood flow. And to make a long story short, it matches up and maintains a gradient across all of that interface, so that the highest concentrations in the blood plasma are matched with the highest concentrations in the filtrate. And the lowest concentrations in the blood plasma are associated with the lowest concentrations in the filtrate. These countercurrent mechanisms are exceptionally powerful mechanisms. We see it in thermal regulation and some other places too, but here it's in the kidney. All right. So the fluid flow of the blood plasma, when it's interfacing with the kidney tubule, is in the opposite direction of the tubule fluid motion. It's a countercurrent mechanism. All right, it creates and sustains a gradient. Vasa recta, that's just the name of the blood vessel mesh that's around the nephron tubules. All right, we see the same thing out in the collecting ducts. So it's a powerful, powerful way of ensuring that we're always matching concentrations so that whatever direction we want things to move, they stay moving in that direction. So we're going to take a pause right here. We're about halfway through the slides, and we will see you again in part 2. Thanks for your time.